Good morning. My name is Sharmila Bhattarai. More than 1 million Australians. That's right. More than 1 million Australians are affected by chronic heart failure, CHF, and almost one-third of them lives in New South Wales. Acute exacerbation of heart failure has become one of the major issues presenting in hospital, with a statistic of one person every 8 minutes being hospitalized. Today, I'm presenting one of the high priority clinical manifestations of heart failure. I will also talk about the underlying pathophysiology of the clinical manifestation presented in the case study of Mrs. Brown. Finally, a high priority nursing intervention to improve her clinical manifestation will be presented. A high priority clinical manifestation I would like to discuss about presented in the case study of Mrs. Brown is oxygen saturation of 85% in room air. Another important factor is the pathophysiology that caused low oxygen saturation followed by dyspnea and bilateral basal crackles. The third area to be discussed today will be about the use of oxygen and other nursing interventions that can be done to improve the condition of Mrs. Brown. As we know, heart is responsible to pump out blood throughout the body. One of its major functions is to receive deoxygenated blood via superior and inferior vena cava, which is then sent to lungs through pulmonary artery where it gets oxygenated. The oxygenated blood gets back to the chambers of the heart, and finally it is pumped out to different parts of the body via aorta. This mechanism of action of the heart is important to supply the oxygenated blood demand of the body that keeps the cells alive. However, during heart failure, the cardiac output of the heart is not enough to meet the oxygen needs of the tissues and organs. This can promote decrease in tissue perfusion, impaired gas exchange, fluid volume imbalance, and decreased functional ability. The cardiac output of the heart depends on preload, afterload, myocardial contractility, and heart rate, which affects the stroke volume SV, which is the amount of the blood pumped per heartbeat. Any changes in these factors can prevail upon decreased ventricular function and heart failure. Acute decompensated heart failure, ADHF, is an increase in symptoms of heart failure when the heart is not able to pump the blood effectively that is collected in the left ventricle. The inability of the left ventricle to eject the blood effectively provokes low stroke volume, and as a result, it backs up into the left atrium. Because of the blood hold up in left atrium, fluid is then flowed into the lungs, causing pulmonary congestion. When there is increase in pressure in the lungs, there will be leakage of fluids into the alveoli. That creates a condition called pulmonary edema, which is often caused due to left ventricle LV failure. Therefore, auscultation of lungs identified bilateral basal crackles due to fluid buildup inside the lungs in the case study. The decrease in vital capacity and reduction in oxygenation can easily provoke dyspnea, and low oxygen saturation in the blood is presented in the case study of Mrs. Brown. She was also presented with other clinical manifestations associated with acute exacerbation of chronic heart failure, such as high heart rate and pulse rate. The decrease in cardiac output accompanied with chronic heart failure is associated with decreased irrigation in the kidney, anemia, renal failure, and renal insufficiency if left unmanaged. To recap on the points made earlier, the presentation of the clinical manifestation such as low oxygen saturation, dyspnea, and bilateral basal crackles have interrelated pathophysiology of decrease in cardiac output. Now, I would like to draw your attention towards the high priority nursing intervention that can be done to improve the clinical manifestation of Mrs. Brown. Patients with acute exacerbation of chronic heart failure requires continuous monitoring and assessment. Stable patient can be managed in an emergency department. However, unstable patients are managed in intensive care unit. In the case study of Mrs. Brown, one of the clinical manifestations that requires immediate management is low oxygen saturation with dyspnea. Therefore, my high priority nursing intervention will be assessment of airway and optimize airway position. To do so, it is important to position her in a high Fowler's position with the feet horizontal in the bed. This position will help to decrease venous return because of the pooling of the blood in the extremities and increases thoracic cavity. As a result, Mrs. Brown's breathing will be improved. Secondly, an oxygen via mask or nasal prongs can be administered to maintain the oxygen saturation level. Another important factor to note is the assessment of vital signs regularly. Continuous pulse oximetry is recommended and regular monitoring is needed to reduce any further complications of hyperoxia. If the clinical indications are left untreated with immediate interventions mentioned above, it may originate cardiogenic shock, self-death due to inadequate oxygen, and can be fatal. In conclusion, one of the high priority clinical manifestations presented by Mrs. Brown is the low oxygen saturation with dyspnea and bilateral basal crackles that is caused due to decrease in cardiac output and pulmonary edema. Based on her condition, it is evident that one of the major nursing interventions to improve her condition would be delivery of oxygen and positioning her in a high Fowler's position. Thank you for your time.